I think we're in a time of great change in both these cancers. So certainly in bladder cancer, we've seen the EV pembro regimen, that's enfortumab vedotin plus pembrolizumab, really changing the paradigm not only in first-line metastatic disease, but also in muscle-invasive disease, where two trials, EV303 and EV304, has established this regimen in that setting. So this regimen is better than platinum-based chemotherapy in terms of event-free survival, overall survival, and importantly, pathologic complete response rates. And the pathologic complete response rates are pushing towards 60% and 64% in patients who have a radical cystectomy, which means that maybe we need to think about whether all these bladders need to be removed. So it really sets the stage for exploring bladder-sparing approaches. And I think we probably need to define what bladder-sparing approaches mean a little bit better. In some people's minds, it means not doing anything to the bladder, so no surgery or no radiation. But in other people's minds, it means doing radiation therapy with or without chemotherapy. So I think we really need to aim to define things a little bit better in that context. In the presentation today, we saw a study where they were looking at the addition of immunotherapy into a concurrent chemotherapy regimen. So it's really trying to understand how we integrate these different therapies. The other thing we saw today was really looking at the patient-reported outcomes for patients who were treated with EV pembro on the EV303 trial. And I think these are really, really critical because as we push towards curing patients, as we push towards having them live longer and live better, a key consideration is what is the quality of that life? How are they actually doing? And so I think there's been a lot of attention at this meeting looking at quality of life. How do we collect it? When do we collect it? How do we collect it to ensure that we're actually capturing the patient view and ideas? So that's sort of where we were in this session. We also talked about the adjuvant setting in kidney cancer, and certainly we've had a number of mixed results in that setting. We saw another study that was negative with durvalumab as a single agent, but the interesting thing about that study is it was tested in a study, it was an investigator-initiated study, where the other arm of the study was durvalumab plus tremelimumab. So we're starting to understand, or starting to try and understand at least, what are the contributions of the different components of these adjuvant therapies. And I think we're still waiting for some biomarkers to help us tell us what we should be doing. And then the final presentation of my session was really interesting. It was trying to see if a patient developed scale to understand the impacts of treatment on quality of life might be a little bit more informative than what we've been doing so far. And I think this will be a really important step going forwards. I think understanding quality of life in every setting is going to be critical, using the right tools, and also assessing this issue of decision regret. So if patients are not happy with what happens, we need to understand why that is.